everyone. I'm Jane Tillman Irving, the president of the New York Press Club. We're happy to report that our virtual speakers series has been wildly successful since its debut last fall. And today, another pinnacle. We are honored to have as our guest Dr. Anthony Fauci. Our series is supported by a generous grant from Consolidated Edison, and as always, we are most grateful. Dr. Anthony Fauci is the chief medical advisor to President Biden. He has been the voice of reason and the most trusted source of information since the inception of the COVID-19 pandemic, despite pandemic deniers from President Trump on down. Dr. Fauci was born in Brooklyn, attended Regis High School in Manhattan before going on to the College of the Holy Cross and Cornell Medical School. He has been the director of the National Institute of Allergy and Infectious Diseases since 1984. He is an expert on HIV and was awarded the Presidential Medal of Freedom by President George W. Bush for his expertise on AIDS. Interviewing Dr. Fauci is Steve Scott, a morning anchor at WCBS Newsradio 880 and a former president of the New York Press Club. Welcome, Dr. Fauci and Steve Scott.
Jane Tillman Irving, thank you, and welcome everyone to this installment of the New York Press Club's virtual speakers series. It's so great to have you all with us today. Now, before we get to Dr. Fauci, we would like to hear your questions. So please submit your questions. Here's how you do it. If you're in full screen, hit escape. That will allow you to exit full screen. You'll see the button where it says submit, and you can put your question in there. We're already getting a lot of questions. We won't be able to get to all of them, but we're going to get to as many as we can in the 40 minutes or so that we have Dr. Fauci today. Now, without any further ado, please welcome the pride of Brooklyn, Dr. Anthony Fauci. Welcome to the New York Press Club, Doctor.
Thank you, Steve. It's good to be with you. A real pleasure. Looking forward to the discussion.
Let's start with some vaccine news, because there is some breaking news today about Johnson & Johnson and the trials. Were the trial results what you expected and what you hoped for?
Well, what we wanted to see was yet again another successful platform that was used. You know, the two that have now been approved in the sense of an emergency use authorization were using mRNA, and that was the Pfizer and the Moderna product. Those were extraordinarily efficacious, 94 to 95% for mild to moderate disease, and virtually 100% efficacious for advanced disease with a good safety profile. We were looking forward to more candidates. The one that was announced, there were two actually announced today. The one that I was involved in a press conference with was the Janssen or Johnson & Johnson, which uses a different platform. It's an adenovirus vector as opposed to an mRNA, which is just another type of a vaccine. The results were interesting because it was conducted in the United States as well as South Africa and in Brazil. And there's some very interesting things. First of all, the efficacy in the United States was 72%. Now, at first glance, that might not seem as good as 94, 95%, but the important part of the whole thing was that for advanced severe disease, it was quite effective. Overall, it was about 85% effective, and there were no hospitalizations or deaths in the individuals who were vaccinated, which is very good news. So although the number of efficacy number, namely 72%, wasn't as impressive as 94, 95, it is clearly value added, both in the United States and importantly for developing nations for the following reasons. It's a single dose vaccine, not a two-dose vaccine. It's relatively inexpensive. It doesn't require a very stringent cold chain as opposed, minus 90 some odd degrees for a freezer. It just requires a refrigerator. So that makes it easier to get to places that don't have the capabilities of that cold chain. And besides, the manufacturer could provide literally billions of doses over a couple of years. So good news today.
You're right. 72% doesn't sound as good as 94, 95%, but it's good enough.
Well, certainly. I mean, if you take a look particularly at what we're trying to do is to prevent hospitalizations, severe disease, and death. So although it was not as good as a couple of the others in preventing early symptomatic disease, what it did do very well was prevent severe disease, including hospitalization and death. So it's the kind of thing that obviously, if we didn't have a 94, 95% effective vaccine that was given an EUA some time ago, a 72% efficacious would have been, wow, this is really terrific. Everything is relative, as it were.
It is a one-shot vaccine versus a two-shot vaccine for Pfizer and Moderna. Some have said a one-shot vaccine could be a game changer. Do you agree?
Well, yes, because, there are a lot of situations where it might be difficult logistically to get people to come back for a second shot. And there are going to be different situations, different demographic groups, different geographic locations in which one vaccine might be more suited than another. And I think that's a good reason for having what we call, more than one shot on goal. You have a number of different candidates and you utilize them to the best way using their strengths to whatever particular result you're looking for. So the other thing I might mention is that another result that was announced today was a Novavax, which is yet again another different type of a vaccine platform, a recombinant soluble protein with an adjuvant. And there was a phase 3 trial in the UK, which was similar to the situation here in the United States, because they have a variant, a mutant that now came over to the United States. That efficacy was just about 90%. It was 89.7%. So that's another now, the third platform and the fourth vaccine. Of note, we are testing that vaccine, that the results I just gave you a moment ago for the UK, we're currently testing that in the United States in a 30,000 person trial, 16,000 of which have already been enrolled. So I believe by March or April, we likely will get results from that trial. And if they're as successful in the United States as it was in the UK, that would give us 4 candidates. So the science of how we're addressing this outbreak is really very, very, very positive.
4 candidates, but right now only 2 vaccines on the market. When do you think
Correct.
we will see more vaccines actually out there getting shots in arms?
Well, first of all, I just a minor correction, Steve. It's not on the market. It's an emergency use authorization. So you can't go into a drugstore, and buy it. It's given out.
You're not supposed to.
No, they're not supposed to. I would imagine that the J&J, will be putting in for an emergency use authorization. I would imagine literally within a week or two. And then it's up to the FDA. I don't want to get ahead of them and predict what they'll do, but the data look robust enough that they likely will go ahead with it, which means probably by sometime mid to end February, we start to be getting some doses in. And then as we get into March, April, May, and June, the company, Johnson & Johnson, has contracted with the federal government to provide by June 100 million doses. So since this is a single shot regimen, that would mean 100 million people, which is really quite good. Because, we have 330 million people in the country. We want to vaccinate at least 70 to 85% of them. So we're going in the right direction. As the weeks and months go by, we'll get more vaccine. The more and more we get, the more we'll put into people, and hopefully we'll continue with the president's goal and projection of 100 million doses in 100 days, and even beyond that, because we really want to get as many people vaccinated as quickly as we possibly can.
We're getting some great questions from our audience, and one is, are these mRNA vaccines, is that the way of the future? This certainly is not Dr. Salk's polio vaccine.
No, it's not. It's relatively speaking a brand new vaccine platform. It has never resulted in a licensed vaccine yet. And when we started the clinical trials, there were, a fair number of people that were somewhat skeptical that we're putting so much hope in a brand new technology, but it has performed beyond our expectations. I would not actually, to be quite frank with you, I would not have expected that we would have two of those mRNA, each of which would have somewhere around 94 to 95% efficacy, but we do. So in answer to the questioner, the person who sent in that question, I believe, as many of my colleagues do, that looking ahead in the future, this platform technology will be used in a number of different diseases. I'm sure HIV, working on that already, malaria, tuberculosis, and even some cancer vaccines will likely utilize the mRNA technology.
A question from our friends at Thomson Reuters who are with us today. They have to do with the data coming out of South Africa, that variant. What does that do to the efficacy of the Moderna Pfizer vaccines? Can we expect the efficacy to remain about the same now that we have these new variants playing in?
You never predict before the data, but I think here's one that you probably can. When you look at the Janssen and you look at the Novavax that had the opportunity to utilize a vaccine in South Africa with this mutant, this lineage 351 lineage, clearly the efficacy was not as good as against the wild type or the standard strains that had been circulating. For example, in the Novavax one that had about a 90% efficacy in the UK, when you looked in Republic of South Africa, it was somewhere around 59 or so percent. So clearly, the mutants have a diminishing effect on the efficacy of the vaccines. Fortunately, in the study that I just mentioned from Janssen, even though it was diminished for mild to moderate disease, when you looked at really severe disease, it did pretty well. But in direct answer to your question, you would expect that with these mutants, which are trying to escape from control, either by the immune system or other interventions, those kinds of mutations are something that you have to be concerned about and pay attention to. And what we're doing, Steve, is that we're making already, in case we have to use it to try and stay a step ahead of the game, versions of the current vaccines that have been upgraded to be able to be directed specifically against some of the mutants, particularly the mutant in South Africa, which is the most troublesome one.
I think this question from one of our viewers, a lot of us could ask, these mutations, these variants, which ones keep you awake at night? Which ones are you most worried about?
The one that hasn't happened yet, Steve. I don't mean to be facetious. We know about the South African one. We actually have the capability of responding to it with upgrading vaccine. There is one that has been dominant in the UK. We even have a version of our own mutant in California, in Los Angeles. What's going to happen, and this is inevitable, that this virus, which is an RNA virus, and RNA viruses tend to mutate readily. Not every mutation has a functional consequence, but some do, either by making it more transmissible, by making the virus more virulent, or by evading the vaccines. So what we have to do, when you ask me what keeps me up at night, is having a situation where we have a mutant that really escapes everything. I don't think that's the case because our technology is such that you could always make a vaccine pretty quickly with this advanced technology that you could address a given mutant. But it is concerning that you need to stay ahead of these mutants and essentially crush this outbreak so that there's no more replication. And when there's no more replication, you're not going to have any mutations, because viruses need to replicate to mutate. So if we can very aggressively control the outbreak in the United States and globally, then we won't have to worry about it. But we have a long way to go to do that. I might mention what I just said a second ago, that since this is a pandemic, it's a global problem. So our suppressing things in the United States is good, of course, but the threat will always exist if there's a lot of infection throughout the world. So we have to pull together as a global community and make sure that vaccine becomes available all over the world, even those countries that don't have the economic capability of either developing or producing vaccines on their own. And the WHO is leading an effort called COVAX, which is aimed at just that, making sure that countries that don't have the capability of making vaccines on their own do have an equitable distribution of the vaccines.
Will these mutations, different variants, different strains, will they lead to us needing to get a COVID shot every year, kind of like we do with the seasonal flu, where there's a different strain and they gear it towards that? Is that what is in our future for COVID?
We don't know, Steve, but it is conceivable that that's the case. I hope not. I hope we get enough control over it and suppress it enough that it doesn't have the capability of doing that drifting or cycling each year to be a little bit different. But we have to be realistic and keep our antennas up, our eyes open, our ears ringing to go to make sure that if those things happen, we're all over it. And I might say we are well into trying to figure out how we can stay a step or two ahead of this game.
Chain issues, some places running out of vaccine, other places seem to have unused vaccine stockpiled. What's it going to take to fix that and smooth out getting shots in arms?
Yeah, that's a great question. That's on the highest priority of President Biden and Vice President Harris, as they've said right from the beginning, to do whatever it takes to get more vaccines out there, to open up the lanes of people getting vaccinated, to get more and more groups to be open up to get vaccinated, to utilize where appropriate the Defense Production Act, for example, to make these dead space needles that allow you to get an extra dose out of the Pfizer vial. You get 6 doses instead of 5, but also to do things like open up community vaccine centers, to get the pharmacies fully engaged in being distribution vehicles for the vaccine, and even to get mobile units to go out into the communities that don't have very good access to pharmacies or to community vaccine centers. So there's a whole array of initiatives that is part of President Biden's comprehensive, now 100+ page strategic plan and the strategy to address COVID-19.
In New York City, Mayor de Blasio has raised the idea of using vaccine intended for second shots, using those as first shots to get more people inoculated with at least one shot and then worrying about the second shot supply later. Is that a good idea?
Well, if you have confidence, which we are getting greater and greater confidence, that the flow of predicted numbers of vaccine that are going to come your way will in fact come on time, you could do that. You would not necessarily need to hold back for the second shot. You can give first shots on a given day, and then the next supply or shipment that comes in, you will always make the first priority, making sure that people get their second shot when their second shot becomes due. And then the rest of them you give for the first shot. And if you keep doing that and the flow of the vaccine, the cadence, as they call it, is reliable, which it has been lately, the fact is you can do exactly what Mayor de Blasio is talking about.
We've had a couple of viewers ask about vaccine safety for people who are pregnant or may become pregnant, and also for those who are immunocompromised. Are these vaccines safe for those individuals?
Well, right now, they have not been tested in the clinical trial. So being pregnant and knowing that you were pregnant was an exclusion criteria for the trial. Immunosuppression, if you're on a drug, an immunosuppressive drug, was an exclusion criteria. However, since the EUA has been given, more than 10,000 pregnant women have gotten vaccinations, and the FDA is following that, and there have been no red flags of safety concern thus far. Regarding people who are immunosuppressed, there's not a safety issue for them, but the question arises, as you might expect, if you have a suppressed immune system for one reason or other, you might not get as robust a response to the vaccine. So it might not elicit as good an immune response. But there doesn't appear to be any safety issue. If this were a live, attenuated vaccine, then you might have a safety issue in an immunosuppressed person or in a pregnant woman. But it isn't. It's an mRNA. The one we were talking about today was a non-replicating vector, an adenovector virus. So those kind of safety issues are not existent when you ask of the two categories that you just mentioned.
Here's an interesting question. Some people say that when they get the shot, they have a little arm pain. And so they want to take ibuprofen or acetaminophen to maybe cut down on the pain. And there have been some reports that that could blunt the effects of the vaccine, that it's not good for you. Can you straighten that out?
Yeah, I mean, that's a great question. You know, theoretically, if you are on a immunosuppressive drug, like a glucocorticoid, a steroid, that's different than taking a Tylenol if your arm hurts. So even though there are some people who say, well, you know, if your arm hurts a little, you don't really want to take a Tylenol, you know, to soothe it down, or you get a fever, you don't want to do that. I doubt if it's going to make a major impact on the result of the vaccine, though there will be those who argue about that. I, as a physician, would not hesitate if my arm really hurted to take a Tylenol. I don't think it's going to have a major impact on your immune response.
We have some parents with us today, and they want to know about schools. The CDC has said that it's okay for schools to open for in-person learning if the rules are followed: masks, social distancing, and the like. Teachers, some are saying they don't feel safe in the schools. Is it safe to open up the schools and send the kids back in?
Well, as President Biden has said, he's going to do everything he can to get K-8 back in the schools in the first 100 days of his presidency. However, associated with that is the need to make sure that resources are supplied for the schools, for the teachers, and for the education team. And that is enough resources so that there are masks, that you could have good ventilation, that you could have a necessary degree of physical separation, that as quickly as you possibly can, you want to vaccinate the teachers to alleviate their own concern as well as for their own safety, to make sure that you have whatever it needs to be able to safely open the school. So I do believe you can do that. And that's what one of the goals that the president has made very explicit in his plan.
You say K-8. Is it a different ball game for high school and then on to college? I mean, the older kids they like to socialize. It's hard to tell a college freshman or sophomore to stay in your room. You can't get together with your friends.
Yeah, I mean, that's true, but you still want to protect them, and you'd like to get them vaccinated when they appropriately. You want them to wear masks. You want them, and a lot of colleges have successfully employed surveillance testing, where they use a rapid sensitive and specific, easy to utilize antigen test that not to see if a particular individual happens to be infected, but if you just do it in a surveillance way, maybe twice a week or whatever the cadence is of the testing, to get a feel for if fact you have infected people there. And if you do, put them in a place, a dorm or whatever, where you could segregate them from the rest of the college so they don't infect their college community. And you don't even want to send them home, because you don't want to send them home. They'll infect the people there. So a lot of colleges are doing things like opening a specific floor of a dorm so that students who most always, not always, but most of the time, really have a mild course where they're either very minimally symptomatic or not symptomatic at all, just to keep them comfortable for the 10 days or so that you need to keep them out of circulation.
Here's a question asking about just the overall picture of COVID in America. Have we plateaued, and are we in fact maybe starting to inch down the other side of the mountain?
The answer is, if you look at the numbers, yes. We've had 3 surges, as you want to call it. The first was in the late winter, early spring of 2020, when the slope of the curve was like this. That was when it was dominated by New York City metropolitan area that suffered the most of any area of the country. Things came down a bit, and then when we try to open up the economy in the early summer, the same thing, another slope like that. Then, as we went into the late fall, early winter, with the cold season bringing people indoors, with the Thanksgiving holiday, followed by the Christmas and New Year's holiday, we had another surge, but the slope was like that, very, very steep. That's when you had record-breaking numbers of cases per day, 300,000 to 400,000, 4,000 deaths a day, hospitals, way, way, way up in the occupancy. But now, in the last week or so, we're doing just what you alluded to. We're starting to see a plateauing a bit and coming down of cases. But one of the things we have to be careful of is that there are always lags. You get cases, 2-week lag, you get hospitalizations, a week lag, you get intensive care, a week and a half lag, 2 weeks lag, you get deaths. So even though the cases are starting to plateau, we still are going to be seeing disturbing numbers of deaths as we go on. And then if that equilibrates, hopefully everything will be down. Cases, hospitalizations, and deaths.
You mentioned recently that 2 masks are better than 1, and I listened to Dr. Fauci, so I've been using 2 masks recently. Does that really help? Does it increase your protection and prevent you from spreading the virus?
Okay, I'm glad you asked that, Steve, because there's been some confusion of saying, well, if Dr. Fauci says this, but the CDC says that. So the CDC does not recommend, they don't recommend against, but they don't proactively recommend that you wear 2 masks. They don't recommend that you wear an N95. They say very clearly, wear a well-fitted, adequate mask, the one you should be, which is essentially almost all the time. So their very well thought out, appropriate public health message is wear a mask. They don't get into 2 is better than 1 or whatever. So I was asked one time, what do you think about the fact that if it's a physical barrier and it's 1 mask, would you want to wear 2 masks? And I made a common sense observation. Well, if 1 mask is good, it makes common sense that maybe 2 masks are better. So if you want to use 2 masks, I have nothing against wearing 2 masks. In fact, some people wear 2 masks. I do sometimes, and people have seen me with 2 masks, in order to essentially make it more firm and comfortable. So let's say I have this as 1 mask. That's my Institute NIAID. And then you get another one that you do to essentially make it all firm. So there's no scientific study that I know of that says this one is better than this one. But to me, it just makes common sense that if you want to feel more comfortable, put on two. That's all. But it's not an official recommendation. Right.
The more
Yeah,
masks, the
better.
merrier, I suppose.
Right, exactly.
We have a question from a Broadway fan. When can I go back to Broadway to a full house, no social distance seating? When do you think that Broadway could reopen?
You know, I can't give a definitive date on that, but I can give some hint about what I believe would happen. You know, I've spoken many times about that we would need about 70 to 85% of the population to be vaccinated before you have what we call herd immunity, you know, whereby there's very little chance of there being spread of infection because the level is so low and a substantial proportion of the population is protected themselves and protecting those who have not had the opportunity to get vaccinated or who can't get vaccinated. When you get that low, then you could start to approach a degree of confidence that you're getting back to some degree of normality. I believe that likely could be as early as the early to mid-fall, late fall of 2021. Although you can't guarantee it. There still may be enough infection that you would not want to have theaters or entertainment venues open. But I think there's a reasonable chance that if we do get that number and that percentage of people vaccinated, that we will be able to go to a movie or to go to a theater.
There have been people going to football games. There will be people at the Super Bowl. Are you comfortable with that?
Well, you know, as long as they wear masks and as long as there's physical distancing, that's the point. You can't have people like this now, given the level of infection. But mask wearing and limited capacity seating, I think is reasonable since it's an outdoor event, which really makes a difference. I believe it's outdoor. Where they're playing the Super Bowl in a stadium, it may be indoor. I think it's outdoor. If it's outdoor, it's much better than it. Yeah, right.
There are some people, Dr. Fauci, especially in communities of color, who say they will not get vaccinated, even when it's available for them. They simply don't trust it. They're not going to get the vaccine. What is your message to them?
Well, when you're dealing with communities of color who have hesitancy about vaccines, the first thing you've got to do is rather than act in a pejorative way, like, why do you not want to do that? You don't make any sense. You've got to respect the fact that their hesitancy is based historically on things that were done and perpetrated upon brown and black people that has been historically shameful over the years, going back to something that many people remember, even though they weren't even born then, is the infamous Tuskegee incident, where the federal government and a federally funded health program did something that would be completely unacceptable and unethical. What we've got to tell our brown and black brothers and sisters is that, in fact, things have been put into effect, safeguards that would make that impossible to happen again. So although we respect your concern about the history, is certainly not a good history, that's not going to happen. But then you got to go to the next step, Steve, because they'll say, okay, fine, I got it. Now, I'm a little bit concerned that you all went too fast. So you just found out about the virus in January of 2020, and now you're putting vaccine in the arms of people less than a year later in December. That you're doing things in months that normally would take years. You must have cut corners. You must have been careless. And the answer is no, that getting things done in months as opposed to years is purely a reflection of the extraordinary and spectacular scientific advances in vaccine platform technology, which has allowed us, without compromising safety and without compromising scientific integrity, to get things done really quickly. The next questions they ask is, okay, I got that, but you say it's safe and effective. How do I know that's true? Is this the federal government trying to put something over on us? Or is it the companies trying to make a lot of money? and you say, okay, let's look at what happens. You do a 30,000 person phase 3 trial with Moderna, a 44,000 phase 3 trial with Pfizer, and then you get results. Who looks at the results? Who analyzes them? A completely independent data and safety monitoring board who, when they determine that the data look good enough to say you might want to apply for an EUA, only then does the company get the data and then go to the FDA, and the FDA career scientists look at it together with their own independent advisory committee. And at that point, a decision is made whether it's okay to give somebody a vaccination. So the entire process is both independent and transparent. And if you take the time to explain that, you're not going to win everybody over. But I think a substantial proportion of the people, when they hear that, will say, okay. And in fact, people that we trust are taking it. President Biden, Vice President Harris took it. I took it publicly in front of a TV camera, as did the Secretary of HHS and the Director of NIAID. So if we thought there was a problem with it, we wouldn't be taking it, and we all took it.
We have about 5 minutes left with Dr. Fauci, and our audience may have noticed we've made a concerted effort to keep politics out of this discussion for the most part. But we do have some viewers, Dr. Fauci, who have asked about your time working under President Trump. Specifically, to what level did your frustration rise at times? Did you ever think about quitting, walking away? And did you expect the president to fire you at some point?
Well, I don't want to, Steve, go back and rehash things. I really want to look forward. And that's where I really want to go. People ask that all the time. They want to find out about that. You know, that's in the past. Let's take a look at the things we can do to end this outbreak. Let that be my comment.
Did you ever think about quitting?
No, I mean, that I'm happy to answer. I never thought about quitting for a second. I just think that the enormity of the task and the responsibility that I had was such that it never even entered my mind to step down and quit. It was just too important a problem that we've been facing.
Dr. Fauci, you turned 80 years old on Christmas Eve. You've
Right.
been on this job for a long time. You've been through SARS, Ebola, Zika, the flu, HIV, AIDS. How much longer will you keep doing this?
You know, Steve, I don't know. I don't focus on a number. You know, age number is irrelevant. It's how you feel, your functional capability. Are you still able to give it 100% or 110%? Are you still up to the task? As long as that is what I have, namely the energy, the capability, and giving 110%, there's no limit. When I feel, and I'm pretty honest with myself, I have a real good reality testing wife who doesn't hesitate for a second, you know, to give me constructive criticism about things. I'll know when to step down, but I don't see that in the future right now.
Dr. Fauci, I'll leave it with this question. There's that phrase, hindsight is 2020, and boy, does that take on a new meaning during this time. If you could look back 4 months, 6 months, 8, 12 months, is there anything, knowing what you know now, that you might have done differently?
Oh, yeah. I mean, that's the entire issue when you're dealing with an evolving situation that literally changes week by week and month by month, because what you know in January is not what you know in March, April, May. So if we had known certain things very early on, we could have done things differently. But unfortunately, we didn't know it. We only acted on the data that we had. One of the things that was very clear is that we did not know. Chinese didn't tell us. It would have been good if they did. But early on, it was not clear that this virus not only spreads extremely efficiently, but that at least 40% of the infections have no symptoms, and 50% of all the transmission occur from a person who has no symptoms. So when you're looking around for symptomatic people to do identification, isolation, and contact tracing, what we didn't know is that underneath the radar screen, this virus was spreading undetected in many people who were not symptomatic. Had we known that, we may have acted very differently about the kinds of things we would do.
As a physician, I mean, it's easier to diagnose somebody who is showing symptoms. They're coughing, they have a fever, they have chest problems, they can't breathe. But if they're asymptomatic, that's got to be frustrating to find then that a person actually has the virus and is passing it on.
You're absolutely correct, Steve. And that's the reason why we did not, but if we had known better, we should have done much, much more widespread testing of asymptomatic people. It's called surveillance testing. You don't just test someone who has a symptom. You do widespread testing in the community to determine the penetrance of infection in the community.
Dr. Fauci, you've been very generous with your time today. On behalf of the New York Press Club, thank you very much for joining us, and best of luck as we move forward from here.
Thank you, Steve. I appreciate you having me. Thank you very much.
That's it for this installment of the New York Press Club's virtual speaker series. We thank Dr. Fauci, and we look forward to our next event, which is coming up February 23rd. Yamiche Alcindor, the White House correspondent for PBS, will be our guest. That's a Tuesday evening at 7:30, and our president, Jane Tillman Irving, will moderate that discussion with Yamiche Alcindor. On behalf of the New York Press Club, and with gratitude to Con Edison for their generous support, I'm Steve Scott. And once again, here's Jane Tillman Irving.
Thank you, Dr. Anthony Fauci, for being with us today and for all you're doing to keep America informed, safe, and on the road to recovery. Thank you, Steve Scott, for inviting Dr. Fauci and conducting the interview. Our members and friends may be wondering if the Press Club plans to hold its annual awards competition this year. It's been a year like no other, so much great work, of course we do. Keep watching our website, www.nypressclub.org. You'll also find links to our videos of our previous conversations and information about our upcoming speakers. We'd like to thank you for being with us, and thank Con Ed, of course, for its ongoing support. I'm Jane Tillman Irving for the New York Press Club. Thank you for being with us. Stay safe. We'll see you next month.